Welcome to This Explainer. Today, we're literally building the ultimate modern surgeon's toolkit. We'll be pulling together a massive amount of surgical practice, from high-tech diagnostics and robotics, all the way down to pathology, cancer biology, and the crucial ethical frameworks that keep patients safe. Modern surgery isn't just about cutting anymore. It's a wildly complex, fascinating symphony of disciplines working together to save lives.
Okay, let's map this out. We've got 5 main stops on our journey today. First, seeing the unseen. Second, tissue, cells, and molecules. Third, the hallmarks of cancer. Fourth, the minimal access revolution. And finally, the surgeon's compass. Let's jump right in.
Section 1. Seeing the unseen.
So, let's start with endoscopy, which has been an absolute game changer. Historically, doctors had to make major incisions just to see what was going wrong inside. Now, we use highly specialized flexible instruments to navigate the inner linings, the mucosal surfaces of the gastrointestinal, respiratory, or urological tracts. And it's evolved way beyond just taking a look around. It is now an incredibly active diagnostic and therapeutic platform.
To put that into perspective, think about the massive shift here. We used to perform diagnostic endoscopy just to find a problem, like spotting a polyp. But with therapeutic endoscopy, a surgeon can find that exact same polyp and safely remove it right then and there, using something called a hot snare that can cleanly slice off a growth entirely, completely saving the patient from needing a highly invasive open surgery later on. Talk about a huge win for the patient.
And the technology gets even cooler. Take narrowband imaging, for example. By manipulating the precise wavelengths of light, specifically filtering for distinct blue and green bands, surgeons can essentially perform an optical biopsy. This creates insanely high-contrast images, revealing the subtle abnormal blood vessel networks of early, superficial cancers that regular white light would just totally miss.
Moving right along to Section 2. Tissue, cells, and molecules. We're zooming all the way in now.
Back in the 19th century, pathologist Rudolf Virchow coined the famous phrase, omnis cellula a cellula, every cell from a cell. This brilliant insight literally laid the foundation for modern pathology. It's the recognition that cancer and disease aren't just mysterious, uniform masses, they're fundamentally cellular anomalies. To really fight the disease, you have to understand the specific malfunctioning cells driving it.
So how do we actually do that in practice? Well, it's a precise, 3-step dance between the surgeon and the pathologist. First, you extract a representative tissue sample, the biopsy. But what if the patient is literally open on the operating table and we need answers right now? That's where step 2 comes in, the frozen section. We rapidly freeze fresh tissue for immediate mid-surgery analysis. Then, step 3 is the meticulous, microscopic assessment to determine exactly what we're dealing with. It's a high-stakes balance of rapid speed and absolute diagnostic precision.
What the pathologists are desperately looking for here is cellular differentiation. If tumor cells are well differentiated, they still kind of look and act like their healthy, normal neighbors. But if they're poorly differentiated, that means they've lost their normal architectural structure entirely. They're chaotic. And for the surgeon, that's a massive red flag, indicating a much more aggressive disease and a tougher prognosis, which directly dictates how radically they need to treat it. Section 3. The hallmarks of cancer. Let's look at the actual biological battleground.
Cancer cells are essentially the ultimate rogue agents. Researchers mapped out these specific hallmarks to explain exactly how these cells survive and spread against all odds. They established their own autonomous lineage, completely bypassing the body's normal control signals that tell them to stop growing. They managed to survive in hypoxic or super low oxygen environments that would instantly kill a normal cell. They even pull off something called the Warburg effect, basically rewiring their metabolism to burn glucose without oxygen so they can fiercely outcompete healthy tissue for resources. It's diabolical, but biologically brilliant.
And of course, understanding a patient's genetic foundation is a huge piece of this puzzle. Highly penetrant inherited mutations can serve as incredibly accurate predictors for future disease. For instance, if a patient inherits a mutation in the APC gene, it almost guarantees they will develop colorectal cancer. Knowing this allows surgeons to step in with preventative prophylactic surgeries before the cancer ever truly takes hold. In these cases, the genetic code literally writes the surgical strategy.
Now, here is a truly mind-blowing number for you, 30. It takes exactly 30 generations of exponential cell division for just one single cancerous cell to multiply into 1 billion cells.
And it's only at that 1 billion cell mark, when the tumor is about 10 millimeters across, that it finally reaches the threshold where we can clinically detect it. Just think about how long that tumor has been quietly, silently growing before we even know it's there.
Section 4, the minimal access revolution. We've got our diagnoses. We understand the biology. Now, how do we physically approach the disease?
The evolution of surgical access over the last century is just wild. Back in 1901, Kelling was doing the very first laparoscopy on a dog. Jump to 1987, and Moray performs the first video laparoscopic gallbladder removal on a human. Fast forward to today, and we're using incredibly advanced modular robotic systems like Versius. It proves that we are constantly, obsessively refining how we access the human body to make it as safe as humanly possible.
And the why behind this minimal access revolution is pretty simple. Reducing the surgeon's physical footprint drastically reduces the somatic trauma to the patient. By making the tiniest incisions possible, we're slashing the rates of wound infections and painful herniations. Patients experience way less pain, they lose less body heat during the operation, and they get their mobility back so much faster. It completely transforms the dreaded post-operative recovery into something totally manageable.
But the technological leap from traditional laparoscopy to modern robotics, that is entirely next level. With standard laparoscopy, the surgeon is looking at a 2D monitor and using these rigid, straight-stick instruments. It absolutely works, but it's ergonomically limiting. Robotic surgery completely shatters those limits. The surgeon sits at a teleoperated console immersed in gorgeous 3D high-definition vision. The robot actively filters out natural human hand tremors, and the articulated instruments can bend and rotate in ways a human hand simply can't. It is unprecedented micro-level precision.
Section 5, the surgeon's compass. For our final section, we need to step back from the lasers and the robots to talk about ethics.
Here is the foundational question every modern surgeon has to face at some point. When does a surgical innovation become an experiment? Think about it. There's this massive moral tension in the operating room. On one hand, you have a duty to do whatever it takes to get an individual patient out of trouble, which might mean trying a novel technique. But on the other hand, you absolutely cannot conduct unproven risky research on a whim.
To navigate that ethical minefield, we rely heavily on strict national regulatory guidelines. Organizations like NICE exist to scrutinize new interventional procedures rigorously. Before any new technique becomes standard practice, it has to be definitively proven safe, efficacious, and actually cost-effective. It's the ultimate safeguard to make sure the potential benefits truly outweigh the unknown risks.
At the end of the day, a surgeon's internal compass is calibrated by a few core professional duties. You protect life to an acceptable standard, meaning you only perform procedures you are legitimately trained for. You fiercely respect patient autonomy and ensure proper informed consent. You willingly submit to clinical audits and keep an eye on your colleagues' performance to maintain high standards. It is all about prioritizing clinical safety and evidence-based practice above all else.
So, as we wrap up this explainer, I'm going to leave you with a final provocative thought. As artificial intelligence and autonomous robots become permanent fixtures in the operating room, as smart tissue robots start actually performing complex surgical connections entirely on their own, how will our ethical frameworks hold up? If a fully autonomous robot makes a mistake, who is accountable? And ultimately, how will the very definition of what it means to be a surgeon evolve in the years to come? It's a wildly fascinating frontier, and we are only just beginning to navigate it.